Good evening.
Hi, good evening.
Okay. So,
Can you hear me, Priyanka?
We can hear you, sir.
So are we going to start?
yes, sir. Good evening. Welcome you all to monthly neonatal clinical update by Ceylon Association of Neonatologists in collaboration with Perinatal Society of Sri Lanka. So I invite President Perinatal Society of Sri Lanka, Dr. Saman Kumara, so for you to give a brief introduction about today's session.
Thank you, Priyanka. I warmly welcome all of you to this very important update lectures conducted by Ceylon Association of Neonatologists in collaboration with Perinatal Society of Sri Lanka. So this is the second lecture, and we are doing this every month, and we are doing two lectures. The first one for consultants and the trainees, and the second one for the junior doctors and nursing staff. So this is the second one for the month of February. So we are going to listen to Nimesha Gamhewage, consultant neonatologist. She will be introduced later on an important topic. And I also want to mention, I have invited one of my friends from USA. He's Dr. Nitin. Not sure whether he has joined us yet. Priyanka, can you see whether he has joined? I'm not sure whether he has joined yet, but he promised me that he will be joining our virtual platform. Dr. Nitin is one of the consultant neonatologists from USA, and he's a very unique person for us. He's the one who actually donated with Professor Uday Devaska the first ever cooling machine to Sri Lanka, to Castle Street Hospital. And he has been doing a lot of works around cooling, and he has special interest about cooling. Therefore, I invited him to join us today just to get some input about controversies in cooling. So having that in mind, without wasting time, may I invite Priyanka to introduce the speaker today. Thank you, everyone. Thank you.
Thank you, sir. Yes. Today we are going to have a case-based discussion on approach to a baby following resuscitation at birth. Today presenter is Dr. Nimesha Gamhewage. She is a consultant neonatologist and a senior lecturer attached to Department of Pediatrics, University of Sri Jayawardhanapura. Over to you, Nimesha.
Thank you so much, Dr. Priyanka. Good evening, everyone. Thank you so much. I would like to thank Ceylon Association of Neonatologists for giving me this opportunity to deliver the lecture tonight. So during the next 1 hour, I'll be taking you through a couple of case scenarios which are common, which all of us encounter in our day-to-day practice, all related to hypoxic ischemic encephalopathy in neonates, and then we'll discuss how to approach these babies in a rational manner. So I'll be discussing about the indications, maybe contraindications of cooling, and common clinical scenarios or dilemmas that we face while cooling. And also, I'll try to give you an insight to the interpretation of CFM. Right. So this is our first case. A baby born at 39 weeks of gestation via emergency section for pathological CTG. Born floppy blue, irregular breathing, and heart rate less than 100. And needed some resuscitation with inflation breaths, ventilation breaths. You can see the APGAR score 5-7-10. And soon after delivery, soon after resuscitation, baby appears to be hypertonic, however, stable on room air. And you can see the cord gases. You can see the arterial gases with a pH of 7, significant base deficit of -17, and a slightly high lactate of 5. Okay, what do you want to do for this baby? Are you going to cool this baby straight away, or are you going to wait with this baby? For you to decide on what to be done for this baby, you need to know what criteria are there for us to consider whether to cool or not. So there are two criteria that we talk about when we talk about therapeutic hypothermia. That is criteria A and criteria B. So if you take criteria A, this describes whether there is any sort of an asphyxial element in the infant. So in a baby with a gestation of more than 36 weeks, if you have at least one of the following criteria, that baby meets criteria A. So what are those criteria? APGAR score of 5 or less than 5 at 10 minutes, need for resuscitation at 10 minutes, and pH of less than 7 or base deficit of more than -16. So these two criteria should be there in either the cord gas or a blood gas taken within the first 60 minutes of life. So criteria B, it describes the presence of encephalopathy in the baby. So what are they? Either the baby should have seizures, which could be clinical seizures or subclinical seizures detected in the CFM, that is amplitude integrated EEG, or presence of moderate to severe encephalopathy. Now, when we talk about moderate to severe encephalopathy, it should consist of this triad. And if you are talking about cooling criteria B, we should have all three. That is altered state of consciousness plus abnormal tone plus abnormal primitive reflexes. Just having one of these three criteria does not meet criteria B. But having said that, please remember, if the infant has seizures, irrespective of these criteria, that infant meets criteria B. So that is the general idea of criteria A and B, which are quite useful, and we need to know thoroughly when we are dealing with a baby who had hypoxic ischemic encephalopathy. Right. So if we go back to our baby, you can clearly see that this baby has met criteria A, base deficit of more than -17. But there is no indication whatsoever whether this baby has developed criteria B or not. So what are you supposed to do in this type of a baby? I have mentioned in my case that this baby is quite stable in room air, but initial assessment, baby looks hypertonic. So what do you want to do with this baby? Yeah. So then you need to keep on assessing this baby whether he develops criteria B. Now in the criteria B assessment, we concentrate on the consciousness level of the baby. So that includes response to stimulation. So a baby will meet criteria if a baby is either poorly responsive or in a comatose state, not if he's irritable. So you can see that only the shaded area are the criteria that we consider as factors that we consider for cooling. Right, going into the next parameter, tone. So again, you can assess clinically the tone of the baby. If the tone is decreased and the baby appears flaccid, then that is a criteria for cooling, coming under tone. Okay, what is the next parameter that we are going to assess? That is the primitive reflexes. Again, it's the absence or diminution of primitive reflexes that we are going to consider. So you are checking the morose reflex, you are checking the sucking reflex. If the baby is having weak sucking or absent moro reflex or partial moro reflex, then that baby comes into the shaded area. So please note that exaggerated moro doesn't come into the shaded area. So you keep on monitoring this child 1 to 2 hourly for the first 6 hours of life to see if this baby fulfills criteria B. So in case this baby develops, fulfills criteria B only, we are going to start cooling for the baby. So should you admit the baby to an ICU for observation? Not necessary. This baby, if stable and maintaining normal saturations on room air, and is able to suckle from the mother, then you can keep with the mom and you can go to the baby time to time, every 1 hour, and keep on assessing the baby. Yeah. So this is an important message for you to remember, that if any infant who needed resuscitation at birth, you need to do a gas, ideally a cord gas. But if that is not available, then it's all right for you to go to the baby and do at least a capillary blood gas or a venous blood gas, and then assess whether there's a significant acidemia. And if a baby meets criteria A, then you need to go back to this baby and keep on assessing the baby if initially this baby appears okay. And also, something important for you to remember is that most of the time, these infants can appear depressed soon after your resuscitation. But many of these babies, they recover spontaneously. Therefore, you can assess criteria B and record in your notes shortly after delivery, but you should make sure that you go back and reassess the baby when the baby is more than 30 minutes of age to allow time for spontaneous recovery post-resuscitation. So the first proper assessment, neurological assessment, should occur around 30 minutes of life, just to allow for spontaneous recovery. If there is good recovery, then there is absolute no need for you to consider cooling. But you need to monitor this baby for the next 6 hours. I hope that's clear. And if you have any queries, you can always ask questions. Moving on to the case scenario, the second case scenario. We have a baby born at term, emergency section for pathological CTG. This baby is also born quite poorly at birth, needed resuscitation. 5, 6, 8 are the ABGA scores, and you can see the cord gases given here. You can see a significant acidosis there. So does this baby meet criteria A? Yes, of course, baby meets criteria A. Can I ask you one question at this moment? We have seen some, and in some centers, whenever there is an ongoing resuscitation, we have seen some doctors switching off the heater. Is that really indicated? Anyway, somebody can argue, anyway, we are going to institute therapeutic hypothermia for this type of baby. So why not start cooling now itself? But please remember, you should never do that. Why? This is quite uncontrolled. The baby can go into significant hypothermia that can worsen the outcome. So during the initial period, you should try and maintain normothermic situation in this baby during the resuscitation. When the baby is in the NICU, then you can commence cooling in a controlled manner. Right. Okay, so this baby was admitted to the NICU and was started on some high flow therapy as the baby had respiratory distress. And he met criteria A. And during assessment, you note that the baby is having poorly responsive, reduced tone, weak sucking reflex. Baby doesn't have any obvious clinical seizures, and the CFM we haven't still attached. Now, should you cool or not? Yes, so this is a definite yes, because this baby meets criteria A and B. So you should strongly consider and start cooling in this baby. I hope the criteria are quite clear now. So in this scenario, again, criteria A, you have significant acidosis, and under criteria B, you have fulfilled all these criteria: abnormal state of consciousness, abnormal tone, and abnormal primitive reflexes. So we should start cooling within first 6 hours of birth, because that's when you can improve the outcome of these babies. But it's ideal if you could start cooling within 3 hours of birth to have better outcome. And what's the temperature? 33 to 34. And you should do it quickly. You should cool the babies quickly to bring into this temperature. And we need to continue this temperature for 72 hours. Right. So do we have evidence to say that cooling is the best mode of treatment available currently? Yes, we do have evidence to say that. So we know that therapeutic hypothermia leads to significant reduction in death or major neurodevelopmental disability at 18 months. And this benefit is observed in both moderate and severe HIE babies. If you take the number to treat, to save one baby, In moderate HIE, you have to treat 6 babies to see 1 good response. In severe HIE, you have to treat 7 babies to get 1 good response. And we also know that it causes increased survival with normal neurological outcome at 18 months. So 40% of the babies who underwent cooling will have good outcomes. Do we have long-term outcomes? Yes, we do. Better cognitive and neurodevelopmental outcome at 6 to 7 years. But you have to also note that nearly 1/2 of these babies who undergo cooling die or can have disability at 18 months. And also, the utility for cooling has not been studied for some group of babies, that is severe IUGR, mild encephalopathy, and also preterm babies. With that background knowledge, we'll move on to the next scenario. We have a term baby born via normal vaginal delivery, good birth weight, uncomplicated delivery. Now this baby is in the postnatal ward with mom. Unfortunately, around 10 hours of age, baby was found to be collapsed. The ward staff did a very good resuscitation, and the resuscitation was quite successful. And this baby is now admitted to the NICU, intubated and connected to the ventilator, and we are starting some inotropes as well. Would you consider cooling in this baby? Yes. So there are some situations which comes outside the typical cooling criteria that we could consider cooling. Although there are no randomized control trials to show the efficacy, we have case reports, case series, and also reviews which suggest that if you cool these babies who do not belong to these typical criteria, still we could get some positive effect. So what are these exceptions? Infants who fulfill criteria A and B, but miss that critical 6-hour period. So even if you have a baby who had HIE, but you could not cool during the first 6 hours, now the baby is 10 hours old, please consider cooling. And also, typically, conventionally, we say cooling is for babies above 36. But we have studies to say, okay, it is good even in babies who are above 33 weeks of gestation. So this is the scenario that we discussed just a second ago, that is acute postnatal collapse. Again, studies have shown good results. And those who had coming with early, prolonged, or recurrent seizures within 12 hours of birth, there are some case series or isolated case reports to show that there is some benefit for these babies also if they undergo cooling. And then there are some babies, I'm sure most of you might have encountered this category of babies who fulfill criteria A, but only partially fulfill criteria B. These are the babies who would have abnormal reflexes, abnormal tone, but might appear a little bit irritable, but not comatose or, totally flaccid. So you can consider cooling in these babies as well. So now that we are thorough in the criteria, please try to remember the exceptions as well, because we can save more babies. Are there contraindications to cooling? Well, the only absolute contraindication would be the presence of other life-threatening congenital abnormalities. Example, encephalus, like a lethal cranial malformation. But there are some relative contraindications that you would like to consider. These are suspected significant hemorrhage, because with cooling, it's sometimes extremely difficult for us to control this bleeding. And also severe PPHN, if you're finding it extremely difficult to maintain good oxygenation despite providing adequate medical support, then you might have to consider withholding cooling for those babies. And also surgical conditions likely to be associated with significant blood loss. But remember, those situations are extremely rare. Right, moving on to scenario 4. Now we have a baby. Now we have already decided, okay, we are going ahead with the cooling. And now the CFM has been connected. And then comes the problem. So most of the time, many units still struggle to get a good CFM trace. That's mainly because we don't know how to attach the CFM correctly. So in the CFM, we have to note that there are nice 5 probes coming out in this machine. And we have to make sure that we attach these electrodes correctly in the scalp. So if you note in this picture that you can see these are the ears of the baby and this is the nose. So this is the anterior part of the head and this is the posterior part of the hand. And then if you correlate these electrodes nicely, then you can attach these electrodes to the baby without a problem. So if you have a measuring tape, this is a specific tape that comes with the cooling machine. With the CFM monitor, and that if you have that, that makes your life easy. So it's very easy to use this tape. You can note that there are several, this tape is marked here with letters A, B, C, D, E, F, and so on. What you need to do is you need to identify the triggers of the baby there and also the sagittal suture here. Then you need to adjust this tape to make sure that whatever the letter you get around at the triggers, you should get it at the sagittal suture as well. And then you can see this arrow here, and then you mark the anterior electrode here, posterior electrode here. So you do it on the other side as well, and then you can get the correct positioning for the scalp electrodes. And then you have a baseline electrode, which you can conveniently attach either onto the forehead or to the back of the baby. Right. So once you have, this is how you measure it, a clearer picture. So you identify the tragus and the sagittal suture and make sure the same letter is shown in this area as well as this area. And then you conveniently mark where you need to place your electrodes. Right. So once you have done it, you will get the trace. So now I'm going to discuss with you about the background patterns of CFM that we might see. So when it comes to CFM, there are two patterns that we need to be familiar with. That is the background pattern and then identification of the seizure. So let's go through the background patterns. So there are 5 background patterns as you can see here. So this is the normal pattern, and then we are moving towards poorly prognostic patterns. Right? So if you take the first pattern, the normal pattern, I will show you a closer view. Right. So in this slide, you can see that in this trace, you can get the lower margin of the CFM trace, and then you can get the upper margin of the CFM trace. So in the lower margin of the CFM trace, if that is a normal trace, then that should be above 5 in the CFM trace. I hope you can appreciate it in this picture. And if you take the upper margin, that should be above 10. At the same time, you can see that time to time, this pattern narrows down and then widens. So that is called sleep-wake cycling. So if you have an infant with this CFM pattern, where the lower margin is above 5, upper margin is above 10, and sleep-wake cycling, that's normal CFM trace. That's a very good prognostic sign. Our next one is a moderately abnormal trace, which is commonly known as a discontinuous normal voltage. So here you can see that if you go to the lower margin, it is sometimes below or around 5, and the upper margin can be above 10. But you can appreciate that there is no sleep-wake cycling in this trace. So that is a moderately abnormal trace, also known as discontinuous trace. Now we are moving towards poor prognostic signs, poor prognostic traces. This is a burst suppression. You can see that the lower border is below 5 and also the upper border is also below 5. So this is the trace I'm talking about, the thicker line. And these are just the bursts. So this is called burst suppression. Like moving on to a burst trace, even a burst trace. So this is a low voltage. You can just see that even the bursts are not there. So this carries even a poorer prognosis. And this is the worst of all, that is the flat trace. You can't see any electrical activity of the brain at all. So this picture, I thought I'll share with you out of interest. This I have taken from a patient that I have managed during my overseas training. You can see that this is just a flat trace. But what can you see in the EEG? Does it look like the ECG? Yes, it exactly is the ECG. It's just the cardiac impulse which is being transmitted to your EEG. That's all you can see in this baby, right? Okay, so this type of patterns also you might encounter in your clinical practice. Okay, now we are moving on to our next scenario. Yeah, so we have a term baby, again, normal vaginal delivery, depressed at birth, who initially fulfilled criteria A and B. But to our surprise, this baby quickly normalized. We started cooling, but the baby quickly normalized, normal tone, normal activity, normal reflexes. And this is the CFM on admission to the unit. You can appreciate that the upper border is around 5. Lower border is around 5, upper border is about 10, but there is no sleep wake cycling. So this is a discontinuous pattern. And then within about 3-4 hours, it has got normalized. Now you have a lower border above 5, upper border above 10 with sleep wake cycling. So what do you want to do with this type of a baby? Can you consider rewarming? Yes, you can. So you can consider rewarming following active cooling only if your baby is completely normal in your clinical examination, plus you have a completely normal CFM. But the CFM should normalize within the first 6 hours. Sometimes you might see that the CFM normalizes after the first 6 hours. In that scenario, you cannot rewarm these babies. You have to continue cooling for 72 hours. So that's because of the cooling itself that the CFM pattern and the baby has improved. So you can consider rewarming quite soon, only during the first 6 hours, if the baby is completely normal with a completely normal CFM. Okay. Right. So for a baby who had HIE, instituting therapeutic hypothermia per se is not sufficient. You have to start supportive management for this type of babies, which would include adequate oxygenation, ventilation, cardiovascular support, fluid support, nutrition, and then monitoring and correction of coagulopathy, analgesics, sedatives, seizures, above all, talking to parents. Right, let's go through one by one. Oxygenation and ventilation. We have to do most of the time, frequently, I can't say most of the time, frequently these babies might need some form of respiratory support, and some of these babies might need intubation and ventilation due to depression of the respiratory status. So irrespective of the respiratory support, they need frequent blood gases. But you need to ensure when you are ventilating, especially if you are ventilating this type of a baby, is to make sure that you maintain normocapnia. So something to remember in this type of a scenario is, unless there had been an associated meconium aspiration syndrome, a term baby with HIE would have normal lungs. So we shouldn't be using very high settings for these babies, because they can quickly wash out the CO2, and that is not, that could be harmful for the brain. As we are talking about cooling, you have to make sure, although the baby is cooled, you have to make sure the ventilator gases are warmed and humidified in the normal way. You should not cool the ventilator gases. Okay? And also, you might have to suction these babies frequently, because when you are cooling a baby, the secretions tend to be more viscous. To help with these secretions, you can change the position of the baby also quite frequently, and also start chest physio as indicated. Right. With that background, let's move on to the next scenario. We have a baby being cooled, and we are ventilating this baby, and you can see quite low ventilator settings, PEEP of 14, PEEP of 5. We have set the rate at 40. But you can see in the machine, the actual rate is hitting around 70 to 80 and FiO2 of 21%. And in the blood gas, you can see quite acidotic, but you can see the PCO2, there's a significant washout. So this is a very common scenario when you are dealing with a baby whom we are cooling. This is mainly due to acidosis of the baby, which triggers the ventilation. So because of the acidosis, there is the baby hyperventilates. So the ventilator identifies this and then keeps on supporting the baby, and this leads to washout of the carbon dioxide, which is harmful for the baby. We should not allow that to happen. So what can you do in this scenario? So sometimes you might see, this is especially for the trainees who are waiting to go for foreign training. So some of the units conventionally use SIPPV mode or the AC mode in our terminology for their ventilation. That's what they use in some units routinely. So if a baby is on AC mode or SIPPV mode, whatever the breath taken by the baby will be supported by the ventilator. So if a baby is breathing at a rate of 70, all these breaths will be supported. And then there's no wonder that this baby is going to have a significant washout of carbon dioxide. So if that is the case, you can simply convert it to SIMV, where you know that only the set rate will be supported by the ventilator. And please make sure that there is no auto triggering. We can commonly see that there are a lot of fluid in the ventilator tubes, which will also act like a triggering for the ventilator because of the fluid movement. So the ventilator recognize this fluid pattern as a breath initiated by the baby and start triggering. So that will lead to CO2 washout. If all this doesn't work, maybe you can try and increase the trigger number of the ventilator. And also it's worth considering whether actually this baby is extubatable, right? If that is the case, you can extubate the baby, right? Moving on to the cardiovascular support. So yeah, most of the babies would need some form of cardiovascular support. So we have to make sure that the vitals are monitored regularly, and also invasive blood pressure monitoring is preferred in this scenario. And treatment with volume replacement and inotropes should be considered if the MAP is less than 40. How about analgesics and sedative therapy? These are indicated because these babies are under stress, and also it's not very comfortable to stay in that hypothermic environment. So that itself will induce stress. And this will have adverse effects on this asphyxiated brain, which we should try and avoid. So how can you identify this? A very easy way is to look at the heart rate. If you are cooling a baby, the heart rate should be generally below or around 100. If a baby who is being cooled is having a heart rate above 110, then that means either this baby is hypovolemic or having pain. So in which scenario, you have to act accordingly. So if you think that is in all the babies who undergo cooling, you have to make sure that you start some form of sedation for these type of babies. So something commonly used and recommended would be intravenous morphine. How about self-ventilated babies? Would you still start morphine? Yes, you should start morphine. But what if they go into breathing failure? Well, that's okay. What you have to do is you have to start a morphine infusion, but you have to keep on monitoring the baby to see if the baby is developing insufficient breathing apneic episodes, in which case you might have to go for invasive ventilation. But just because you are scared that this baby will stop breathing, you should not prevent giving sedation for this baby who is undergoing therapeutic hypothermia. And also there's an implication for the babies who are moving out. Let's say you have a baby self-ventilated in air, and you are hoping to take this baby out to another tertiary care center for cooling. And you want to start, because the baby is in significant pain, you want to start some morphine for this baby. So you have to make sure that you don't fly with the baby as soon as you give the morphine bolus. Why? You have to wait until you see the actual effects on the respiratory depression for this baby. As soon as you give it, so you have to at least wait for 30 minutes, because some of these babies will go into respiratory depression, in which case you have to stabilize the airway and breathing, and next you can move on with your transport. So please remember those two scenarios. Fluid and electrolyte management is also very important. We know that the renal function is commonly impaired. Therefore, we go for a restricted fluid regime at 40 ml per kg. And we need to monitor the renal function, including the urine output. And we should avoid nephrotoxic medication as well. And maintaining normoglycemia is also extremely important to prevent secondary brain injury. Therefore, sugar should be monitored 4 to 6 hourly. And you need to have good vascular access, including UVC and UAC, because it's a nightmare to put a cannula or take blood in a baby who is undergoing cooling. And also, but there could be some cases where you fail to put a UAC or a peripheral outline, in which case you might have to still do some capillary blood gases. One practical tip that I could share is to you can warm that area of the heel that you want to puncture with some warm saline put into a glove, and you can warm that bit of heel only and then puncture and get the blood. Okay, feeding in a baby who is undergoing cooling had been a controversial area. Many would say they are a bit scared to start and go up in the feeds because they are concerned that this ischemic cut can lead to necrotizing enterocolitis in this baby who has already had HIE. But there is enough evidence for us to say that feeding during therapeutic hypothermia is harmless and in fact could be quite beneficial for the baby. But we should never ever give formula feeds for these babies because that's going to increase your risk of necrotizing enterocolitis. What you can safely do is you can get whatever the milk coming out from the mother and give that amount of milk as available produced by the mother for this baby. But you need to monitor the feed tolerance of the baby carefully. How about coagulation? So we all know that due to HIE itself, and also maybe due to some effects of cooling, there could be some element of coagulopathy. Therefore, you need to monitor the platelet count as well as clotting at the start of cooling, as well as while we are cooling the baby. So when we are just about to start cooling, if you see that the baby is having features of bleeding, then you don't need to wait for your investigations. You can transfuse some FFP and correct the coagulopathy. But if baby develops significant bleeding while on therapeutic hypothermia, but the first step would be to give an FFP as soon as possible. Next, you can still consider rewarming the baby by about 0.5 to 1 centigrade if it is really difficult for you to control the bleeding, and you can go back to your therapeutic hypothermia temperature once the bleeding is settled. Okay, so one of the very common complications that we encounter in babies with HIE is neonatal seizures. Can we identify all seizures clinically? No, we cannot. Studies show that we can identify clinically only about 1/3 of seizures clinically. So that's why it's very important for us to start CFM monitoring for these babies, because that's a very good method to identify seizures in these type of babies. So who will need treatment? All those babies who are having symptomatic seizures. That is, if you see a clinical seizures, you have to treat it. If those are subclinical seizures, meaning you can't see it clinically, but you can see them in the CFM, then if you are having about 3 seizures per hour, then you need to consider treatment. Having said that, I would like to emphasize this fact that a doctor should always keep on going to the baby who is on the CFM monitoring at least hourly, and keep on reviewing the CFM monitor to ensure that we have not missed any seizures. It's very unfortunate to see sometimes that when you review after about 6 hours, you see that there are many missed seizures just because somebody forgot to review the CFM, and that should not happen at any cost. Okay. So how do you identify a seizure in your CFM? It's very easy. So you can see a sudden increase in the background pattern like this. So this is the background, and you can see all of a sudden the background has gone up. And also the trace gets narrow. Okay, and if you see the EEG trace, you can see a nice rhythmical pattern, and that's a seizure. So this is another seizure. These are some of the seizures that I have captured during my foreign training. You can see that the baby is in a status. Okay. See, you can see there is sawtooth appearance. So that is quite different from the traces that I showed previously. This is called a sawtooth appearance. Again, so this type of seizure is also different from what I showed you, what is typically shown in the textbook. So a generalized increase in the baseline, but you can see that here it remains similar to the to the background activity. So this is also a seizure, and I hope you can appreciate the nice waveform in your EEG as well. Okay, so this is another pattern that I have captured. So you can again see the sawtooth appearance, and also you can appreciate the nice waveform in the EEG. It shows that this baby is in a status. Okay, so the management of a baby who is having seizures while being cooled is similar to any other baby who is having seizures. So if you make the decision to treat that seizure, then the first line would be your phenobarbital. After 40, you can move into phenytoin, and then you can consider other second line medication. So remember, when you give these anti-epileptic medications, you can sometimes see a suppression in the CFM pattern also, but that's okay. That's a well-known entity. Okay, so this is one other scenario that we have encountered. That's when we start rewarming of a baby who had seizures during cooling period but controlled. When we start rewarming these babies, all of a sudden they start to have seizures again. So what can we do in those type of babies? You can reconsider recooling these babies to the previous temperature, 33 to 34, and maintain that temperature and extend your duration of cooling by another 1 day. And then you can slowly restart cooling these babies. And there are nice case reports for us to say that that has been quite effective. This is something that I have also experienced during my overseas training. Okay, so now we have talked about detecting seizures in the CFM. So in the middle of the night, your registrar or the medical officer is concerned about a CFM pattern because the baseline has gone up all of a sudden, and has taken this photograph and sent to you asking whether this is a seizure. So what can you say about it? So there are some situations where actually artifacts can mimic a seizure. But if you carefully look here, you can see these red marks. These are actually called impedance. So actually what has happened here is this baby had undergone some form of procedure or some form of handling by the nursing staff. So that's why this activity has got changed. So that's why this red marker has come there onto your CFM trace. If you carefully look at the EEG pattern, you wouldn't see any typical seizure activity in the CFM, in the EEG activity. So that's why it is very important for you to go back and tell to your staff that whenever they are doing any procedure or handling the baby, they have to mark it in the CFM so that you are not getting confused later on when you are reviewing the CFM to see, oh my gosh, I have missed a seizure. This is another scenario. You can see that all of a sudden you can't see any pattern and you see just a teeny trace in the sky of your CFM monitoring. So what is this? This is just your electrodes have got loosened. That's all, right? So all what you have to do in this scenario is to go back, inspect the baby, and then adjust the electrodes. Right, so we are moving on to our next case scenario. A mother presents at term with antepartum hemorrhage. Baby is born very poorly, bradycardic, and intensive resuscitation was performed at the time of birth, including a blood transfusion. And you have noted seizures in the first hour of life itself. And this baby remains quite encephalopathic despite all your interventions, therapeutic hypothermia, and the baby remained ventilated and baby needs inotropes. Let's have a look at the CFM pattern. You can see that it's a flat trace, quite poorly prognostic feature. And this is CFM on admission. And after 24 hours also, things haven't changed. Baby remains encephalopathic, multi-organ failure. And this is the CFM, still the flat trace. 48 hours into cooling, still the same. No improvement at all. So this is a baby who is having very poor prognostic features. So this baby is having persistent abnormal neurological signs at 48 hours, CFM remaining severely abnormal, multi-organ failure, persistent lactic acidosis, then you might wonder whether cooling should be continued or not, whether it's actually beneficial for this baby. So actually, this baby will not benefit from continuation of the cooling. What you can do is you can talk to the parents, discuss about the pros and cons, that it's just prolongation of life only. So you can strongly consider uh, uh, um, stopping cooling or therapeutic hypothermia in this type of a background, because you are going, you know that the prognosis is extremely poor for this baby and this baby is not going to recover. But in actual practical setup, this is quite difficult. Most of the time when you approach the parent and talk to them and explain them, they would still want to continue that one more day of cooling to see if there is any change at all, where you have no choice but to listen to the parents. Okay, with that case, let's talk about prognostic indicators in a baby who suffered hypoxic ischemic encephalopathy. So what are the clinical parameters? So obviously the severity of encephalopathy, if that is a severe encephalopathy, then your prognosis is going to be not so great. And also persistence of neonatal seizures or refractory neonatal seizures. Again, a poor prognostic feature. In your CFM, if you have severe background abnormalities, including the burst suppression, isoelectricity, that is the low voltage, or flat trace, that is a poor prognostic sign. And also, as I've shown in the previous scenario, if this abnormal amplitude integrated EEG persists around 48 hours of age, that's a very poor prognostic sign. So usually the median time to achieve the sleep-wake cycling in the CFM monitoring is around 36 hours. And if that baby is CFM pattern normalizes within 48 hours, at least coming to the discontinuous pattern, then that is a good prognostic sign. But if that baby CFM pattern continuously becomes abnormal at 48 hours, then we know that the outlook is not going to be that great. Okay, in neuroimaging, so MRI brain should be arranged for the baby once the baby has been rewarmed. So we are specifically looking at abnormal signals in the posterior limb of the internal capsule, and also some changes in the basal ganglia and thalami region. Sometimes you might be able to see the brainstem lesion as well. So this is what we call as abnormal signaling of the PLIC, that is the posterior limb of the internal capsule. That's where your motor pathways are concentrated. So if you see any abnormality there, then the prognosis is not that good. Right. We have nearly come to the end of our lecture tonight. So we have spoken about the main form of management in babies with HIE, that's therapeutic hypothermia, and the supportive management. But there are some treatment modalities which are being still tested, but we don't have sufficient data to institute practice into our day-to-day life. So these include erythropoietin, stem cells, melatonin, xenon, allopurinol, magsulfate. There are isolated studies showing the efficacy, at least in the preclinical setup, but there haven't been any major clinical trials as such for us to say, okay, this is safe, this is effective, so you can go ahead with it. We are still waiting for the results of those trials. Okay, so after your initial period of management of a baby who had HIE, then of course there's a long way follow up. So we all know that these babies are at a higher risk of developing neurodisability. Therefore, you have to monitor these babies not only for their development growth, OFC monitoring, looking to see if they develop epilepsy. And we need to make sure that we follow them at least up to about 2 years of life in a tertiary care center. And these babies must undergo a proper developmental assessment. And they should be followed up in the MDT clinic as well, multidisciplinary clinic, to make sure that we help them to achieve their maximum potential. And also we need to look into the hearing vision, and also arrange therapies to improve hearing and vision as well. Yeah, so we have come to the end of our lecture. If you have any questions we would like to take up.
Yes, thank you, Nimesha, for that informative lecture. Actually, it's really eye-opener for the practical aspect of the management of baby following hypoxic ischemic encephalopathy. And I would like to thank the Mankind Pharmaceuticals for their valuable sponsorship for the today's session. And with that, there are some questions already appear in the chat box, which I like to forward to you. Yes, one is, if baby got severe bradycardia during therapeutic hypothermia, what can we do?
Yeah, so bradycardia is quite common during therapeutic hypothermia. Actually, that's something we would like to see also, because we know that the baby is quite comfortable if the baby is having bradycardia. So most of the time, so we generally like to see around 80 to 90, but if that is going even lower, that's when the baby is sleeping actually. So what you can do is you can check with the stimulation. If that is improving, then you don't have to worry at all. If you are really worried, something you could do is to get an ECG done just to make sure that the QT interval is normal. And something to keep in mind is that if the bradycardia is prolonged, you could see whether there are electrolyte abnormalities like a calcium abnormality or a magnesium imbalance, which could sometimes be there in those babies. And if that is there, you can correct it. So I think that should be the approach.
Yes, thank you.
Sir, do you have anything to add on to that, sir?
Well, no, I think that's very common observation. We're talking about bradycardia, right?
Yes, sir. Yeah.
Yes.
Yeah. So I actually answered that question in the chat box. Relative bradycardia is something very common. You can observe heart rate of 90 to 100 during the phase of cooling. But if it becomes really severe bradycardia, then you have to look into why this baby is bradycardic. And very common reason is they can be hypovolemic and hypotensive to become bradycardic. But severe bradycardia is something which I have not observed. So I have cooled at Castle Street Hospital more than 250 babies for the last nearly 5 years. So I have not observed any severe bradycardia, but relative bradycardia of 90 to 100 is very common observation. We don't have to worry about it. With that, I'm just trying to see whether Dr. Nitin is with us. Nitin, are you there?
Yes, I'm here. Thank you for having me.
Hi, Nitin. Can you switch on your camera and just show your face to us, because you are a very important person for us.
I'm available to do that. Just a minute.
Oh, we are driving, right?
Yes, my daughter is going to New York, so I had to go drop her. That's why it took me a minute to join.
Oh, sorry. Just switch off the camera,
No,
and if you
I'm
can.
not driving. My wife is driving. So.
All right. Okay. Thank you for joining, Nitin. Thank you for joining. And actually, I mentioned about you at the beginning of this presentation because you are a landmark person for Sri Lanka, because you helped us with donating the first ever cooling machine to Castle Street Hospital, and which has saved many, many lives, and that initiated the cooling program in Sri Lanka. And now we have nearly 15 places cooling. So thank you. You have been listening to Nimesha's presentation. We have few queries. Hopefully, we can discuss with you as well. I have a question actually. Nitin also and Nimesha. What about using CFM trace to make a decision whether to cool or not? Now, biggest practical problem is not criteria 1. Criteria 1 is very straightforward, and the criteria 2 is very vague, and sometimes we may be missing the babies who are fulfilling criteria, but criteria-wise, criteria B may be vague. So what about using Nitin, CFM monitoring as an indication to start cooling?
Yeah, sir. So actually, it's a good indicator. If you are not sure about criteria B, CFM monitoring could aid with your therapeutic decision. Because if you see a perfectly normal CFM with a relatively normal baby, a neurologically normal baby, then it's likely that this baby is not encephalopathic. But if you see an abnormal CFM pattern, then it's likely that this baby is going to benefit from CFM. One other thing that's important to notice, sometimes you get babies who get sedation or paralysis soon after birth, just to aid the ventilation and oxygenation. Then after about 1 hour, you all of a sudden remember, oh, did I assess criteria B? How can I now assess criteria B? In this setup also, using CFM is quite handy. Because then you can nicely see the encephalopathic status of the baby if you use that.
Yeah, Nitin, you have anything to add?
So interestingly, we have not. We were the center for where the NICHD neonatal network did their study, and we did not use cerebral function monitoring for babies with HIE, and we basically recently have changed to using continuous video EEG throughout the cooling of these babies. So I feel that cerebral function monitoring definitely adds to the diagnostic, but unfortunately, I don't have enough background to use it. Because, truthfully, when CFM was started at Hammersmith Hospital, London, by Dr. Dennis Azopardi, I used to, in 1998, I used to be the senior house officer in that department at Imperial College School of Medicine. And I have seen them doing the tracing on the black drum, the carbon drum, using the very, very crucial crude machine using the needles, inserted into the scalp. So truthfully, but I don't want to claim anything on that. But in the area where the pediatric neurologist may not be available and continuously, regularly, then CFM is a great aid to the diagnosis.
Thank you, Nitin. Thank you. I think one good point is if you Sulakshi, can you unmute yourself? Sulakshi, can you mute please? Sulakshi? Yeah, okay, thank you. And one good point is if you have a baby who might need to go on cooling, it is best that you don't use any kind of paralytic agents or sedation at the beginning before you do the assessment. So when you have given any paralytic agent, and we normally don't give paralytic agents at the beginning for ventilation, unless it's a baby with meconium aspiration, pulmonary hypertension, and struggling baby. Probably might have to use some paralytic agents, but try and avoid at the beginning giving sedation and paralytic agents. Then you get into trouble with assessing criteria B, as Nimesha mentioned.
Someone, I'm Priyankar here from UK. Is that okay? Make a bit of...
Hi Priyankar, how are you?
I'm fine. Thank you. It's happy to see that therapeutic cooling start in the back home and doing so many centers. And I have a bit of comment on the first case scenario, and you also discuss about this marginal case of cooling. So what advice rather than the going for CFM, because of the in UK here as well, that we are running with the peripheral hospital, so they don't have CFM monitors. So they know that the code gas or a clinical criteria A is fulfilled, but the doubt is the criteria B. In these situations, the best practice is outlined by the BAPMM frame of cooling. So if you can Google that, you can find it. Basically, the advice is a modified SONET criteria. So in that case, stage 1, stage 2, and stage 3, you can see, and that will reduce the bias of the examiner, and that will clearly indicate the indications for the criteria B. I mean, basically the neurological. So that situation is very easy to decide whether to transfer to the center where the cooling available within first 6 hours of age of the infant. I'll be able to send out the leaflet through the WhatsApp group so the colleagues can read it and get familiarized with that. Is that okay?
Yeah, that's absolutely okay, yes. Yeah, I think any other questions? And next thing, I think Nimesha mentioned about another case scenario where you think of stopping cooling halfway through. When baby becomes completely active and normal, and the CFM becomes normal. So, you have any comment on that, Nitin?
Truthfully, we do not decrease the length of cooling, even if the baby starts appearing normal after 12 hours or 24 hours of cooling, because it has been shown by studies and in animal as well as human data that the length of cooling is most effect of cooling is most optimal when it is given at 3 hours of age. Having said that, in adults with post uh, cardiac arrest encephalopathy, they cool only for 24 hours and they rewarm in 12 hours. But baby brain physiology definitely is different than the one in adults. And but more studies have to be done for less amount of cooling, less number of hours of cooling, uh, for to see if that is equally optimal to 3 days or 72 hours of cooling. I hope I understood your question correctly.
Yes, yes. It's clear. Thank you.
If started cooling more than 6 hours, we continue cooling in terms of neurological, whatever the shows, whether it's a continuous seizures or the CFM monitoring. But we consider for the reorientations care or comfort care or discontinued cooling in situations where you can't maintain your blood pressures, you can't ventilate, or you are detrimentally bleeding kind of thing is you can't control. So it's not because of the neurological, but because of the other indications with the poor prognosis, we discontinue cooling. But if the other parameters are all right, only this neurological concerns, we continue 72 hours and rewarm the child and then reassess and decide to reorientation.
Yeah, so that's exactly what we have been also doing. And I had to stop cooling maybe once or twice because of severe pulmonary hypertension, which was not under control because we were almost losing the baby. It's a baby with meconium aspiration syndrome with severe pulmonary hypertension and going on nitric oxide. Yeah, so I think that's clear now. Priyanka, do we have any more questions? I have few comments before we go on to that.
Yes, there are a few questions, sir. One is whether, so the Asanga is asking whether passive cooling, how to go for passive cooling when the proper cooling is not available. Is it advisable or what to do now?
I think Nimesha can
Yes.
Yeah, so passive cooling is also an acceptable way of managing babies with HIE if you don't have enough facilities. So there are studies to say that it's effective, but what you need to make sure is that there is a chance that the temperature of the baby can go beyond the safe margins, 33 to 34. So you have to make sure that it does not happen when you are instituting passive cooling for these babies. So as long as you can maintain the temperature within the recommended range, it has been shown to be effective compared to no cooling at all.
Yeah, the difference between passive cooling and active cooling is uh, passive cooling is obviously it's been shown that it's effective, but the smoothness of cooling, because we have to maintain the core temperature 33 to 34, but you can't have a smooth temperature control when you do the passive cooling. But as you observe, obviously you can see when you do active cooling, you can have a very good control of cooling, and the smoothness is very nice, and you can maintain whatever the temperature you like to maintain and then rewarm it. But that process is not very smooth with passive cooling, but something is better than not doing. So when the criteria are fitting, and when the baby needs cooling, you can go for passive cooling. But now actually you have 15 stations in the country where cooling is taking place. You can most of the time you can transfer this baby within 6 hours for a cooling center. I think that's what we should be doing.
And
Yes,
Nimesha,
also we
Yeah,
also have sorry, we also have done passive cooling when a baby has been born in a peripheral hospital and immediate transport is not available. So, and in that case, we do turn off the warmer and we do passive cooling while the baby is ready to be transported.
yeah,
So, and we have been very successful doing that.
yes.
And we now also have cooling during the transport.
Thank you, Nitin. Priyanka, anything else?
yes, sir, the last question, whether this cooling can be applied for a baby with milk aspiration.
Yeah, so that's what we discussed under the exceptions of cooling criteria. So I suppose this is about postnatal collapse is talking about. So if you have a baby with postnatal collapse, you can obviously consider for these babies to undergo therapeutic hypothermia that has in fact been shown to be effective. Yeah.
Yeah, I think we have to probably rephrase the question, Priyanka, just not for milk aspiration, for a baby
Yeah.
who has any event,
Any
postnatal
event,
event,
yeah. Maybe a
just
cardiovascular collapse,
several events,
yeah.
maybe even
Any event, yeah.
kind of asphyxia on the postnatal asphyxia,
Yeah.
any kind of uh, brain damage, which is I think you can there is place for cooling.
Yeah.
Other thing is, I think probably Nitin can add on, because we have done some studies and a lot of we have a lot of interest into uh, other aspects of cooling, like cooling beyond 6 hours of age and cooling less than 36 weeks of gestation, which we are not practicing right now in Sri Lanka. Do you do cooling less than 36 weeks, Nitin? And also, what is your cutoff weight limit? And I think our limit is 1.8 kilograms, if I'm not mistaken.
Yes, we also have the same 1.8 kilogram
Mm.
is the cutoff, and we actually do not cool below 36 weeks. Below 36 weeks of gestation. Um, and so about the cooling beyond 6 hours is also very attending dependent, but the study for delayed cooling showed using the statistics that the uh, the treat, what do you call it? You have to treat 100 babies to get 2 babies to benefit. If you cool beyond uh,
6 hours.
cool beyond 6 hours of life, and therefore some of us, I do cool if I can after 6 hours as well, up to 12 hours, but I haven't cooled beyond 12 hours typically, and I haven't had to cool beyond 12 hours so far.
Yes, there's no data beyond 12 hours, but up to 12 hours, there are some data, but not success as for 6 hours. In the event of this postnatal ward collapse kind of scenarios, up to 12 hours, yes, here in the UK, also we consider to cool. So there are data available on that.
Yes, I think that's clear now. I think there was some concerns about feeding while cooling. I think there's no contraindication for cooling, but if the baby has been very bad at birth and badly resuscitated, and if you suspect severe gut ischemia, in that kind of scenario, probably you may have to keep the baby nil by mouth without feeding.
Particularly if on multiple inotropes, isn't it? Sir?
Yes, yes.
Yes, two things I'm against here, the feeding or not feeding. The people are thinking, okay, the feeding will comfort the baby and give. But basically, these babies, we give some sedations, morphines, they're comfortable. And then the other thing is this baby's lactate levels will not normal during the cooling. So risk and benefit, most of the cases here, we don't feed babies while on cooling. We start feeding after reborn. We give the restricted fluids and maintain the sugar level and keep the comfort baby with the sedations and not consider feeding while on cooling. But there are trials goes on, some publications as well, whether it's safe or not safe. But I think the indications for whether to feed or not, he has to comfort the baby and give some nutrition. But the comfort wise, babies are comfortable while on cooling without feed.
Yeah, I think we have to decide by case. There's no hard and fast rule.
Exactly.
But general feeling was at the beginning of cooling, when the cooling was started, to keep the babies without feeding nil by mouth for 72 hours for the whole duration of cooling. But there was some evidence that you can feed, but I think you have to decide that case by case. You can decide. Nitin, you have anything to add on for feeding?
Yes, in the United States, I don't feed my babies, but in India, wherever I have given cooling machines, they do feed babies who are stable. So, and I think there is a lot of good thing, better if it is breast milk is available. It is always better to put it in the gut to help healing, and breast milk is the best thing to happen for these babies' gut. And I have 100% in agreement for with your assessment of case by case feeding, but I haven't done that in United States yet, because we always have a potential of potential of a problem with a baby. So people are scared of feeding without evidence. So we have to develop actually evidence before we can do that in the USA, because there was in the initial study, when the cooling happened, they did not feed the babies. So therefore people are stuck to that those criterias that started this. So
I think we are not talking about 10-15 ml of milk. We are just talking about maybe half ml or 1 ml of colostrum.
Yeah, that is perfect. That is the right thing to do, and it should benefit. And
I think
because in our
Nishani-
other countries, they have the luxury of having the donor milk, which is not available here. So we are just talking about whatever the milk available from the mother, which will be actually in small quantities, isn't it, sir?
Yeah.
So yeah.
Yeah, very small volume,
Yeah,
but
so
you have to
you,
make sure that the baby is stable.
yeah,
and
but you have to
stable.
monitor the tolerability of the
Yes,
feed.
you are not going to give
Yeah.
feed to the baby with large NG aspirates and blood staining.
Exactly. Yeah, yeah.
And Nishani has raised her hand. Nishani?
Yeah, Samantha, thank you. Just to talk about, just add a comment about the feeding. I believe the reason for withholding feeds, I think during the initial trial and later on, and this mention of the inotropes and the connection with feeding is, I think, all due to the gut reperfusion and the risk of necrotizing enterocolitis. So the thing is, there's lots of evidence saying that, breast milk is actually protective against necrotizing enterocolitis. And as Nimesha mentioned, like when you're using mother's milk, the protection is much more actually than the donor milk. So
I think we are discussing here about not the full
luxury
feed.
that we don't have it, the luxury.
Sorry.
No, what I'm saying is withholding feeds, because we are talking about the early days. No, usually this would be sort of soon after birth for many babies. So the amount of milk will be very small, and whatever is available, if we can give it, I think it will definitely have a beneficial
It will be
effect more than a
beneficial,
risk. But
yeah.
I agree that you should, because it will be few drops actually, isn't it? You're not going to get 20-30 ml of milk on day one for anyone.
That's
So
what
it
I
will
was
just be
Exactly.
few drops.
Yeah.
And we don't really have to say it is 1 ml or 0.5 ml or whatever, but usually what nature does and what the mother gives is usually 2-3 ml even on maybe day 2. So I believe, like, while assessing the baby, we should not put hard and fast rules saying don't feed, and we should more in favor of feeding mother's own milk, because that actually is protective against neck. And I believe that is the reason
and also
why it was avoided in the first place. Yeah.
Yeah, what you can do is you can definitely start with oral care also with colostrum, because that will promote expression
Yeah,
of
yeah, yeah.
and you can use oral.
Yeah, no, because yes.
Oral care.
I have
That's
another
the thing.
comment.
Anyway, Saman, in the first day, yeah, only about of sort of 0.5 ml or even a super mom will give 1 ml, but it's less than 1 ml. So your oral care, that is all you get usually. Yeah. Oral care, nutrition for everything. So I believe that should be actually given and tried, and then if you are having issues with abdominal distension or whatever else, you decide after. But as a policy, I believe it is better to start.
I agree 100%.
Thank you.
I have one more point. I have one more comment about glucose metabolism. And both hypoglycemia and hyperglycemia are detrimental to the already injured brain. So therefore, it would be critical to maintain the glucoses between normal range, about 70 if possible, and below 150 if possible, and try to titrate the glucose infusion accordingly. So hyperglycemia is associated with poor outcomes as well as hypoglycemia. So we need to keep an eye. Then low blood pressures also decreases the cerebral perfusion, and hyperoxia can also cause superoxide damage. So all three things are critically important: maintaining the good glucose levels, maintaining blood pressures, normal CO2s. Low CO2s are also associated with poorer outcomes because low CO2s can cause decreased cerebral perfusion as well. So these are my comments.
Thank you, Nitin. And also, I just want to add, there was little misconception by some of the consultants or some of the trainees sometimes that when you are cooling, the baby has to be on the ventilator. So I just want to make sure that is not the case. You don't have to ventilate. If the baby needs ventilation, breathing support, only you need to offer breathing support, but you don't have to ventilate just for cooling. And this was kind of a little misunderstanding. And some babies were intubated and ventilated for cooling, just for cooling. So you don't have to intubate and ventilate for cooling. And you have to offer respiratory support only if it is indicated. Otherwise, you can cool without respiratory support if the criteria are fitting. Do you have any more questions, Priyanka?
Yes, it's again related to this passive cooling, whether we advise to switch off the transport incubator while transferring.
Yes, I think this is same like switching off the radiant warmer. If you are doing passive cooling, even for the transport, you can do the passive cooling, continue passive cooling even during transport.
Yeah, but that should be done in a controlled manner
that is-
to make sure that there is no, that the temperature doesn't drop beyond that 33. So that you have to ensure. Yeah.
I think it will not be a big issue in our country, in a country like, the climate and, temperature. Maybe in a cold country, that will be a problem. You have to be careful because you might cool the baby unnecessarily to a low temperature if you are not careful with passive cooling when you are doing the transport.
Someone, even if here is the passive cooling when the baby was delivered in the periphery, if a transport cooling is not available, we transfer with the passive cooling. It's not that horrendously, the overcooled babies. I think it's a safe way to do the passive cooling, just to off your whatever the heat generations around you and keep some temperature monitoring with the infant, and you can transfer. So that's something safe.
Yeah, that's right. Yeah.
And one more question. So the initial acidosis that we get in the blood gas, do we advise to correct them with bicarbonate or normal saline boluses?
Yeah. So the acidosis is due to intrauterine hypoxia, as well as there could be continuing acidosis due to low perfusion. All what you can do is assess the perfusion and correct it. If you think the baby is poorly perfused, yes, you can give a fluid bolus and also consider antropes. But just because you see a continuation of blood gas, acidosis in the blood gas, if the baby's perfusion is otherwise okay, you shouldn't be giving unnecessary fluid to the child, because that is also harmful. And something that we see in these babies is that lactate also, sometimes it can persist. It's because you need a good liver to clear the lactate also. So just because you see these parameters, you shouldn't be loading the baby unnecessary with fluid or bicarbonate. One exception would be if you are dealing with a baby with PPHN, difficult to manage, and there to control the PPHN component, then you might have to normalize the pH quickly with the use of bicarbonate. What is your comment about that, sir?
Yeah, I think that's because if the baby has been severely asphyxiated and given cardiac massage and the drugs and all that, obviously the myocardium is weak, and you should not be overloading this baby with unnecessary fluid boluses. And also bicarbonate is something you have to be very careful. You should not be giving bicarbonate unnecessarily. But babies who are relatively bad at birth, or most of them will have wide base excess, and this base excess will definitely settle with time, within a matter of hours, and probably might need a small, maybe 1 bolus 10 ml per kg, but that again, if necessary, after assessing the capillary refilling time and all. But this initial base excess will settle in most of the babies, and they will not need unnecessary bolus and bicarbonate. But you should not be throwing bicarbonate and boluses without any rationale for these babies, because they are already, the myocardium is weak, and the boluses can cause unnecessary trouble. And giving bicarbonate, again, you should be giving bicarbonate only if it is necessary, especially if you are dealing with things like pulmonary hypertension, then probably correction may be indicated.
Agreed 100%.
Thank you, Nitin. Anything else, Priyanka?
So, no, sir, the questions are over. So I think we had a nice lecture and the discussion about the approach to a baby with hypoxic ischemic encephalopathy, and mainly the practical aspect. So mainly, if we can get done the blood gas, the cord blood gas, if the facilities are available, or the very first hour gas, It will be very helpful. And in our setup, if we can transfer them at least in the normothermic state once stabilized for a tertiary center for the therapeutic hypothermia, I think that is the key message that we have to send also. So thank you very much, Nimesha, for your valuable time and the nice presentation. And again, I would like to thank our sponsors today, the Mankind Pharmaceuticals, for their valuable sponsorship. So
and thank you. I want to thank the Mankind Pharmaceuticals for sponsoring this event. And I have a special thank to Nitin and for joining this. I think you are going somewhere and you are busy. So thank you very much, Nitin, for joining us and giving your valuable inputs to this session. And there were about 100 participants to start with. So this is going to save lives, and you have been helping us for almost last 6-7 years, and you continue to help. And he has already come forward to donate a resuscitation machine for my program. And thank you very much, Nitin. So taking your
Yes,
time.
I think that's the least I can do. And it's an honor to know you, Saman, personally. And it's a great pleasure to continue to work with you. And I hope to continue to work with you and potentially create a program, more organized program for cooling and optimize the therapy for babies with birth asphyxia in the future. And we just started with a small abstract that we submitted for cooling, and you contributed significantly to that. And I'm honored to be part of this movement, and I hope to contribute as much as I can.
Thank you, Nitin. Thank you.
Thank you,
Please
sir.
stay
Thank
safe.
you, Dr. Nitin.
And I thank all of you
Thank
for
you.
joining this important lecture. So we'll hope to see you again next month. So just remember that we will be having this every month. Some important topic will be discussed. And also this will follow some quiz, and later on we'll have a certificate. And also we will have some system of giving CPD points for these lectures, and people who score high points will be given free tickets for Penguin Society annual sessions. So with that, I take this opportunity to thank everyone and hand over to Priyanka for final remarks. Thank you very much. Good night, everyone.
So thank you very much for the presenter and all the participants who joined today's session, and wish you all a very good night. Thank you.